we know that from the literature, it says that significant intravesical prostate protrusion has been shown to cause bladder outlet obstruction. On the other hand, storage symptoms can be secondary to bladder outlet obstruction. So therefore, it's very valuable and interesting to know whether there is a significant correlation between IPP and the storage symptom. So in this study, we investigate the correlation between the subjective symptom and the parameters of urodynamic and imaging studies in male patients with a non-neurogenic overactive bladder, and to see whether there is a significant correlation between IPP and the storage symptom. We recruit male patients more than 60 years old in our outpatient department. We exclude neurogenic comorbidity such as CVA, Parkinson's disease, diabetes, neuropathy, and etc. We evaluate symptom severity using International Prostate Symptom Score, and we calculate total score and the voting subscore and the storage subscore. We also use overactive bladder symptom score, OABSS, as suggested by Dr. Homer from Tokyo University. For urodynamic study, we did catheter-free uroflowmetry. We also measured post-voiding residual urine during pressure flow study. We also calculated bladder outlet obstruction index according to ICS nomogram. We checked PSA. We also did transabdominal ultrasound to measure the prostate size and to measure intravesical prostate protrusion, and also to measure the detrusor wall thickness. To measure intravesical prostate protrusion, we use transabdominal ultrasound, sagittal view of bladder and the prostate to measure the protrusion from the tip of the prostate to the base of the bladder. We also measure the detrusor wall thickness over anterior bladder wall. We correlate the correlation between subjective symptom score and objective urodynamic study and imaging studies to correlate their relationship. Totally, we have 122 male patients, the mean age 72 years old. The symptom score is as shown on the slide. The correlation between the symptom score with uroflowmetry and the PSA, it shows that for the symptom score, IPSS symptom score, total score, voting score, and storage score correlated with Q mean and Q maximum flow rate. For the correlation between OABSS symptom score, it correlated very well with maximum flow rate. And also, PSA has very good correlation with total IPSS and the IPSS storage subscore. Regarding the correlation between symptom score and the urodynamic parameters, we found that IPSS storage score correlated well with CMG capacity. It also similar, correlated well with OABSS and the CMG capacity. It also found that IPSS storage score correlated well with post-voiding residual urine amount. Regarding the symptom score, correlation with the symptom score with sonographic finding, we found that intravesical prostate protrusion correlated well with IPSS storage subscore and also with OAB SS score. It is interesting to note that there's no correlation between prostate size with symptom score, and also there's no correlation between detrusor wall thickness with symptom score. To summarize the result, we found that major finding is IPSS subscore correlated very well with IPP PSA PVR and the Qmax and the CMD capacity. For OAB-SS, it correlated very well with IPP and Qmax. So in summary, we found that IPP consistently correlates well with storage symptom as measured by both IPSS storage subscore and OAB-SS. So in conclusion of our study, in older male patients with non-neurogenic OAB, more severe storage symptom is associated with a lower maximum flow rate, a more prominent intravesical prostate protrusion, indicating that a significant cause of non-neurogenic OAB in older male is prostate-related. Thank you for your attention, and I welcome you to go to Taiwan. Thank you.
It's a very interesting paper. I'm Carlos Ancona from Brazil. Well, how you differentiate IIPP causal obstruction? Because OAB can be a lot of factors can develop these symptoms, like aging, detrusor, obstruction. How you differentiate just IPP is responsible for these symptoms?
So I can follow your question very well.
Yes, how you confirm this IPP is related to OAB?
Yes.
Because we have also obstruction because IPP. Other causes of OAB.
Yes, I agree that OAB in male patient might be due to some other factors, such as neurogenic factors. But we already exclude that kind of patients. I guess you also would like to know patient with detrusor underactivity, detrusor overactivity, detrusor instability with impaired contractility. That's why you ask. DHIC?
No, I ask because also have the detrusor overactivity because of obstruction, and also because aging detrusor. How you define only IPP as a cause?
Aging detrusor also cause OAB. And I agree with that. But in our patients, most of the patients, they have a very good detrusor contractility.
Quick question.
Hello. I agree with Dr. Carlos D'Ancona. My name is Daniel Moser from University of Campinas too. I think it's an excellent exposure, very clearly. But to take out this doubt, maybe we have patients with different ages with IPP, and you should perform a multivariate analysis to exclude this cause. So you can affirm that IPP, there is this relation. It's a suggestion, okay? Thank you.
Well, I think that the methodological issues suggested by our young colleagues is absolutely right. I have two comments to your paper. One, you speak about OAB. You haven't shown us that these patients have OAB, because OAB, if you look at the definition, means urgency. And without urgency, there is no OAB. These are BPH patients having storage symptoms. That is totally different from having OAB. The other point, in the lack of a multivariate analysis, you can't say that IPP is the cause of it. It's not we don't know whether this is an independent parameter. We know that there is correlation, but if you look at the R value, is 0.195. So the correlation is highly significant, but relatively low. It's less than 20%. So over 80% of the symptoms are explained by other factors. So I would really go back, look into a larger patient group, and run a multivariate analysis, because when we published our nomogram, everything that has been published failed in multivariate analysis, and only Qmax and transition zone volume are real predictors of obstruction. So the idea is interesting. None of us ever looked at intraprostatic protrusion versus urgency, but I think we need more work.
Yeah, I thank you for your advice, but we just found a correlation. We cannot say cause, it is cause or the result. I take your comment.
Okay. I'm wondering how you test the detrusor wall by the ultrasound, because we know the detrusor wall depends on the bladder volume. If patient have different bladder volume, maybe the detrusor wall is different.
Yes, we measure the bladder wall thickness at a volume of between 150 and 200. This is according to the literature. Okay. Of course, I understand your point that the thickness of the bladder wall differ with different bladder volumes. We pay attention to this point. Thank you.
Okay, thank you.
Thank you.